Did you know one of the biggest breakthroughs in weight loss started with a venomous lizard? Yeah, this guy right here. He's the Gila Monster. This little guy had the secret in his saliva. But how did this happen? How was this discovered? Well, it was all through diabetes. Like I mentioned in our last video, lowering glucose levels in a patient with diabetes has benefits as far as the patient's eyes, the patient's kidneys, and the patient's nerves, but it does not decrease the patient's overall risk of cardiovascular disease. So the patient still is at high risk for heart attacks and strokes. And that was the main point from the Accord trial that was done in 2008. It was published in the New England Journal of Medicine in 2008, and it pretty much said that patient with diabetes, although decreasing their glucose levels, has some benefits. None of those benefits is decreasing the patient's risk of having a heart attack or stroke or overall cardiovascular disease. To kind of review a little bit from the last video as well, with the A1C to kind of get that better understood, the A1Cs are a way for us to measure the patient's glucose level for the past 3 months or so. So it's a simple blood test. And from that number that we get from the hemoglobin A1C, we can see roughly how high the patient's sugar levels have been over that 3-month period of time. And how this works is, if this is your blood vessel, so this is your blood. In the blood, you have these red blood cells. And in the red blood cells, you have hemoglobin, which is a little protein inside of them. And that gives the blood the kind of red color. But in between the red blood cells, you have other things floating in the blood. And here we're going to focus on these blue X's, which are glucose. Now, this glucose has to get into the cell to provide the cell with energy to do what it has to do. When you focus on a single hemoglobin molecule, you see that occasionally you will have a little glucose stuck to it, attached to it almost. As the patient's sugar level gets higher and higher, so as the patient becomes diabetic essentially, more and more sugar gets in the blood, and so obviously more sugar will get into the red cell. And then more of this tagging happens. And this tagging, we call it glycated hemoglobin. So hemoglobin is stuck with glucose. If you were to get a sample of a patient's blood, and if 6.5% of the hemoglobin or more is tagged with glucose, we say that patient is diabetic. And this is the hemoglobin A1C. We're just asking ourselves, through a blood test, what percentage of the patient's hemoglobin has glucose stuck to it? And if it's over 6.5% of it, then we kind of say, okay, this patient's diabetic. And this roughly equates to 126 milligrams per deciliter of sugar on average. Which again, if you remember back in our prior video, for the fasting blood glucose level, it was about 126. Okay? Again, this A1C may become irrelevant in the near future, especially as continuous glucose monitors are becoming more popular. But as of right now, it's still a commonly done test and important to understand. I think it's very important to really appreciate that what the Accord trial showed, so this trial right here, was very important and unintuitive. If we say the y-axis here is cardiovascular disease risk, so again, how likely is a patient to have a heart attack or a stroke? If you have normal physiology, meaning you don't have diabetes, that risk should be pretty low. And then as that person starts to have issues with their weight, with their blood pressure, having some glucose irregularities where they get a little bit too high, but not high enough to become diabetes, mind you, but just higher than normal, or the cholesterol begins to get a little bit problematic, then that patient develops what's called metabolic syndrome, we talked about also in our last video. It's almost, some people also, this is also in the realm of pre-diabetes. The risk of having a heart attack or a stroke or general cardiovascular disease in these patients is a little bit higher. And then when that patient crosses the line and goes and becomes diabetic, the risk goes even higher. But from our understanding, the main and only thing that separates a metabolic syndrome patient from a diabetic patient is the glucose level. So if that were to be true, normalizing the glucose should decrease the risk of heart attack or stroke back down to at least the metabolic syndrome risk. But that's not what we see. So we are missing something from this picture. So now the focus of diabetes care is not just on lowering the glucose level, but trying to see, hey, can we also decrease the risk of having a heart attack and a stroke? Because when you look at patients with diabetes, they tend to die from heart attack and stroke and the complications thereafter. Okay, so it kind of shifted our focus from being glucose-centric to now being cardio-centric. And that's where this monster comes along, the little Gila Monster that we talked about. Because he has a little hormone in saliva called exendin 4. It's a hormone that reduces gastric emptying. And what that means is the food that's in his stomach or his or her stomach gets pushed into the intestines a little bit slower. 2 is it reduces appetite. This little guy only eats 3 times a year, and that's good enough for its physiology. And 3, it increases insulin release. But when you look at the chemical level, what this hormone is, what this exendin 4 is, we have an analogous hormone in our system that is called GLP-1. Okay? The main distinction, well, one of the main distinctions is that ours doesn't last nearly as long as the Gila Monsters. This intrigue with this little monster's physiology led to a medication called exenatide, which mimics the Gila Monster's hormone. But when given to humans, it does improve the hemoglobin A1C, but not by very much, and it has no effect in cardiovascular disease. Now, because of this attempt going down this pathway, we could have easily just stopped and said, you know what, it looks as if these GLP-1 molecules aren't very helpful. But luckily, researchers did not stop. In 2016, there was this trial called SUSTAIN-6. Took a cousin of exenatide, which is called Semaglutide. This medication is also a GLP-1 agonist, so it works similar to the notion of how the Gila Monster works. And this study was specifically purposed around 2 main focus points. Does it, 1, decrease the patient's glucose levels? Although we know that that's not going to decrease the patient's cardiovascular disease, it has benefits, right? Kidneys are still very important, eyes are still very important, and nerves are still very, very important. So we have to maintain that benefit, or at least determine does medication improve it or not. And then 2, evaluate the patient's cardiovascular disease. Does this medication lower the patient's risk of having a heart attack or a stroke? So those are the 2 main endpoints. And so when you look here at this SUSTAIN-6 outcome, here's the A1C that we talk about. It's called a glycated hemoglobin. I don't call it A1C, but the same thing. Remember, 6.5 is diabetic. Usually, for control of the patient with diabetes, you want to keep the patient around 7 or below. So keep them here. So all these patients started out between 8.5% and 9%. So definitely in diabetic range, glucose levels are quite high. Placebo here means they're taking just a sugar pill. Absolutely not taking any medication that should be helping them whatsoever. Their hemoglobin A1C stays pretty much the same. With the patient taking the semaglutide, these had a significant drop in their A1C. So a good number, especially on the higher dose, we're living around the goal of 7 already. But when we looked here at these 2 graphs, risk of heart attack and risk of stroke, we see here the placebo, so the patient's not taking the medication. And here it is with the medication, and you see a drop. There's a difference between these 2 points. These charts are showing that this medication can lower the risk of having a heart attack or stroke. But there was also another pleasant surprise. In the same trial, in the SUSTAIN-6 trial, here we measure patients' body weight. In the placebo, so those not taking the medication, pretty much had flat weight. But in the semaglutide groups, there was a significant weight loss. This was not a primary outcome of the study. The study wasn't designed to measure this, but when they collected the data, they noticed it. So a very pleasant surprise. It was successful. Remember, the main point of the trial was to say, can you control glucose levels and can you decrease the patient's cardiovascular disease? And those 2 primary outcomes were shown to be positive, that the medication can in fact help in both of those regards. But it also showed that potentially this medication could be significant for some weight loss. So then in 2021, there was a SURPASS trial. And this SURPASS trial showed the same medication, same cousin of the Gila Monster's hormone, but also another one. And this other one actually functions by a second mechanism as well. So they both function by the GLP-1s, but Tirzepatide also works through a second mechanism. And here are the outcome measures here. So for the A1C rate here, you see that from baseline, Semaglutide decreased it by almost 2, whereas Tirzepatide decreased it by over 2 at all 3 doses. Now, it is important to understand that 1 milligram is not the max dose. So we're not comparing max dose of Semaglutide to Tirzepatide, but regardless, both these medications seem to be helpful at decreasing the patient's A1C by a good amount. And now, this study, what separates it from the SUSTAIN 6 trial is that the SURPASS 2 had a primary focus on weight. And when you look at the patient's weight, the semaglutide had a significant drop, and so did all 3 doses of the Tirzepatide. But again, this is not full dose semaglutide. The study itself says that Tirzepatide is probably a better medication, and in fact, it may very well be. This is not full dose. You can be taking 2 milligrams, and just because you double the dose does not mean you're going to double the effect, or at least that shouldn't be assumed. And we can see that very easily here with Tirzepatide, where you see a 7 kilogram weight loss here. With 5, you double it to 10, and then you only get about less than 2 kilos more. So double the dose does not mean double the weight loss, but it is safe to assume that with 2 milligrams of semaglutide, you will see a little bit further weight loss and maybe a little bit better A1C control as well. So again, from our understanding, the main difference between metabolic syndrome and diabetes is sugar. There's no other way for us to diagnose diabetes apart from sugar. But normalizing the sugar does not bring a patient down as far as a cardiovascular risk, but we're not entirely sure why that is. We have a number of theories, but now we have a group of medications that can not only control the patient's hemoglobin A1C and sugar levels, and can not only decrease the risk of having a heart attack and stroke, but can even decrease the patient's weight. One thing that can be really confusing with these medications is they have different names, but they're the same compound, same chemical, same medicine, just different names. Similar to how it was back in the 70s and the 80s with ibuprofen. So ibuprofen is the common name. Some companies making something that's called Advil, another one making something that's called Motrin. But at its core, the exact same medication, just different packaging, maybe different doses. Advil was used over the counter, mainly for like pain and inflammation, whereas Motrin was prescription strength and usually catered more towards females with menstrual pain. Same idea here. These 3 are the common names. These are the names that probably will not change over time. But when you look at the orientation in this direction, these 3 are the exact same thing, just different names. The same with these 3, and the same with these 3. Just depends on what you want to use it for. So if you want to use semaglutide for diabetes, we will call that Ozempic. If you want to use it for weight loss, it's called Wegovy. Tirzepatide, if you want to use it for weight loss, it's called Zepbound. If you want to use it for diabetes, it's called Mounjaro. And if you want to use Liraglutide, Victoza is for diabetes, and Saxenda is for weight loss. Again, different names, same thing, just depending on what you want to use it for. So for insurance companies, if they are told, I would like to have Ozempic, they will assume that the use is for diabetes. If they want to say, I would like to use Wegovy, the assumption will be it is for weight loss. And again, all this started because of this little monster. What is on his saliva opened the door. Their very first attempt at a medication from his saliva was a failure. It wasn't at least as successful because Liraglutide is still used, just not a very helpful medication. But down that path led to something that is much more successful. That can, again, not only control patients' diabetes, but can lower their cardiovascular disease risk and decrease their weight. But what's next? A lot of questions with these medications. We'll have another video down the road where we go into them more in depth, understanding how long they should be taken, what are side effects. But regardless, these are very helpful medications and a big, important turning point in our management of diabetes. Okay? Well, I hope you find this video helpful, and I'll see you guys next time.